Welcome to the Catholic Ethics and Challenge of COVID-19, a live webcast series presented by the Catholic Health Association and Georgetown University in cooperation with the Pellegrino Center for Clinical Bioethics. Thank you for joining us. My name is Ronnie, and I'll be the operator for today's presentation. Before we get started, I'd like to acquaint you with a few features of this web event technology. At any time, you may adjust your audio using your computer volume settings. There will be a question and answer portion of the webinar. To submit a question, just click on the Q&A icon on the bottom toolbar of the Zoom platform and enter your question. Please note that today's presentation is being recorded, and both the recording and slides will be emailed to you. We're joined today by Nate Hibner, Director of Ethics for the Catholic Health Association. This time, I'd like to turn the presentation over to Nate for opening remarks. The floor is yours, Nate.
Thank you very much, Ronnie. Good day and welcome to you all, and thank you for joining us for Part 9 of the special series presented by the Catholic Health Association and Georgetown University entitled Catholic Ethics and the Challenge of COVID-19. Before I introduce today's presenter, let us pause and say a blessing for all those called to be caregivers at this time. May you see with tender eyes the wounds of those before you. May you hear with well-tuned ears the unspoken needs of those whose voices are muted. May you hold with gentle hands the bodies and the spirits of those you care for. May the beauty of soul, the strength of spirit, the wholeness of being lead you, inspire you, and let you know your own beauty of soul, strength of being, wholeness of spirit. May you know that as you care for others, God cares for you, sees you, and holds you tenderly. Amen. We are very honored to be joined today by Dr. Sean Oss from Georgetown University, who will focus on the ethical issues related to disability discrimination and COVID-19. Dr. Oss is a senior research scholar at the Kennedy Institute of Ethics and an assistant professor in the philosophy department at Georgetown University. His primary areas of research are bioethics, metaethics, and social and political philosophy with a significant focus on issues of disability. Welcome, Dr. Oss. Today's event is 30 minutes. If you have any questions for the presenter, please enter them in the Q&A module, and they will be answered as time permits. And I now wish to turn it over to Dr. Oss to begin his presentation. Welcome.
Thank you, Dr. Hibner. So I'll be talking to you today about disability discrimination and COVID-19, and particularly about, primarily probably about ventilators. So as you know, during the first wave of COVID-19, there have been both actual, especially in Italy, and projected or possible shortages of acute care resources, including but not limited to ventilators, right? So apparently, even if you can make more ventilators, there's still a question as to whether there are enough respiratory therapists to actually effectively use them, right? And so a major ethical concern or consideration throughout the pandemic, which will continue to be a concern, if there's a major resurgence, involves a distribution of scarce acute care resources. So when there isn't enough to go around, who should get what? Obviously a difficult ethical question. This doesn't apply just to acute care resources. When vaccines become available, even if the various warp speed and other initiatives to accelerate development and manufacture of vaccine go optimally, there won't be enough doses for everyone in the world or even everyone in the United States immediately. And so there'll be a question about who should get first access to vaccines. So today I want to focus on a sort of sub-question of this, which is about how the fact that someone has a pre-existing condition, right, a disability, should affect their claims on the distribution of resources. And I'll focus primarily on acute care resources using ventilators as an example, but claims to vaccines and the relevance of pre-existing conditions to vaccine distribution will also be on the agenda. Okay, so if we want to know how the medical system should distribute scarce resources, I think we have to ask, what is the medical system supposed to do? Why do we have medicine? Well, the goals of medicine often described in terms of health, but in practice, we often proceed by thinking about evaluating treatments or policies and thinking about not the goods they're supposed to achieve, but the ills they're supposed to avoid. So mortality and morbidity. But I just want to start out by pointing out that although in an acute emergency context, we can focus narrowly on, say, mortality as the goal of preventing someone's imminent death, generally medicine is concerned with the positive goal of extending life, as well as the negative goal of avoiding imminent untimely death. And the same can be said on the side of morbidity, right? So the goals of medicine include preventing rapid worsening of people's conditions, right? The rapid acquisition of pain or significant disability. But that's not all that they include. They also include the goal of improving health and quality of life. So given these goals of medicine, how should medical institutions distribute scarce resources, especially in contexts where this becomes a critical question, as with the distribution of ventilators in conditions of scarcity in the pandemic context? So just to be clear, as a framing point, what I'm talking about here is not microallocation decisions or bedside rationing, right? So the principles that we'll consider aren't principles that the clinician is supposed to apply directly at the bedside, right? What the clinician should have is a policy that's been developed either at the governmental level or the institutional level, which can guide them in making allocation decisions so that the responsibility for these difficult ethical judgments isn't placed solely on their shoulders. Now, I understand that there will be allocation decisions that need to be made, which the policy doesn't settle, or where the policy doesn't make sense. And I'm happy to talk about those in the Q&A. But just to clarify that the principles that we'll consider are principles that are meant to guide the decisions of policymakers, right? And spoiler alert, I don't have the right principles. I'm going to tell you something about which principles we should reject and why, and especially concerns that the disability community will have about various proposed principles for health resource allocation in this context. Okay, so first principle, a principle that actually guides a lot of health philanthropy and health policy in various systems asks health policy to achieve a simple goal, which is to maximize health. Where health is understood as involving both quality and quantity of life, the avoidance of both mortality and morbidity. This principle of resource allocation tells us to try to make as many healthy or happy years of, good years of life as possible. This is sometimes operationalized using a metric known as the quality adjusted life year, or a similar metric known as the disability adjusted life year, a metric which tells us how to evaluate the benefit of a policy or healthcare intervention by asking not just how many total years of life it adds, but asking how good those years are, right? And the way that this works in the case of a quality adjusted life year is that if an intervention or policy adds a year of life that will be completely healthy, it gets, as it were, 1 point. That's one quality, right? One quality adjusted life year. But if the year of life that it will preserve, or the year of life that it will produce, is one in which someone has a significant illness, right? Say they're unable to see, then this will count for less than 1 point, right? There are different what are called weightings of quality of life that go into these metrics. On older ones, conditions like blindness tend to get quite low ratings, like 0.6 or something like that. So a year blind is 3/5 as good as a year sighted. They've come up with new ways of dividing the weightings, which are a bit less detrimental to judgments of the quality of life of people with disabilities. But still, applying this metric, if you had to choose between saving the life of a blind person and a sighted person, who would have equal life expectancy if they get the treatment, this health or quality maximization metric is going to tell you to save the life of a sighted person, because that's producing more healthy life, right? Understood as the goal of medicine than saving the life of someone who is going to be unhealthy one way or another. So, of course, disability advocates have long-standing issues with this framework. We can identify them, I think, under two broad categories. So one is that on one level, it seems sort of unfair, right? If we do think that people who are, say, blind or paraplegic or who have other disabilities, maybe chronic pain, if we think that they're worse off in virtue of having those disabilities, their lives have gone worse, then it seems a bit unfair to punish them further in these critical allocation contexts by saying, we're not going to give you a life-saving resource because the life that we save won't be as good as the life we would save if we saved a healthy person. So that seems problematic in itself. And then also, of course, I'm sure many of you are bristling at the judgment that a disabled person's life is somehow less worthy or less valuable than an able-bodied person. Now, I would, to be fair to the health maximization perspective, want to say that it's not that people who take this perspective are sort of fundamentally ableist and think that disabled people have less sort of moral status or value than able-bodied people. It's supposed to be, the judgment is supposed to fall from the fact that it's the goal of medicine to produce health, right? And so you can produce more health by saving the life of a healthy person. It's not meant to reflect a moral judgment on disabled people or something which is sort of intrinsically insulting. The perspective says, I'm not saying that you're less than, I'm just saying your life is less good than someone else's life. But of course, many disabled people are not at all satisfied with that response, and I personally think very, very reasonably so. So some philosophers, thinking of themselves as speaking on behalf of disabled people, and speaking especially to the first concern that the health maximization principle, the quality maximization scheme, that this is unfair to people who are already badly off, have proposed a principle that focuses our attention not on trying to make as much healthy life as possible, but specifically on helping the neediest, right? So philosophers often refer to this as prioritarianism, to use a fancy word, or priority for the worst off. We could gloss it as saying that we should be attempting in allocating scarce medical resources in the pandemic context, among others, we should be attempting to make the worst off patients as well off as possible. So a first point to note about this is that despite the intention of some of its proponents, it requires certain assumptions if it's going to imply, if it's going to prove beneficial to disabled people in the context of emergency or pandemic allocation. As I was just saying, many disabled people would claim that their lives are in fact no worse than the lives of able-bodied people, no worse even for them to live, right? So people express this in different ways, but it's a common claim made by disability scholars and activists that their disabilities are mere differences, right? So for instance, someone who's deaf might say, it doesn't make my life any worse, it's just different. If that's the case, then this prioritarian, this idea of giving resources to the needy first isn't going to do any good for people who are deaf or have other disabilities of that non-life worsening kinds, because they're not necessarily going to be amongst the needy. And that might actually be all to the good from the perspective of some of those disabled people who would say, no, my life is just as good as someone who doesn't have this disability, and so I don't have any desire or claim to go to the front of the line. But just to point out that this prioritarian principle, right, this priority for the worse off, is not necessarily going to always prioritize disabled people over non-disabled people. Another problem for it, a kind of independent problem, is that for those people with disabilities, which do seem to make them very much worse off, right, people with several chronic conditions which shorten their life expectancy and undermine their quality of life. The patients who are sort of generally medically worse off, right? This principle has us attend to people who are generally medically worse off throughout their lives, not the people who are in the most danger now, right? We'll get to a principle like that. But this this principle that tells us to attend to the people who generally have had the hardest time in life, right, is going to tend to have us devote resources to people who are unlikely to receive much benefit from those resources, right? Because people who are very, very, very sick are, even abstracting from the considerations I was discussing earlier about, the value of different lives. They're just likely, value of different lives over a whole life. They're just less likely, in general, to medically to benefit from treatments, right? People with very serious illnesses are less likely to survive the episode of ventilation and get off the ventilators. So I think that there are various reasons why we wouldn't want to go too far in the direction of a kind of bleeding heart, just give everything to the people who are neediest principle, right? It's going to, in some ways, just be wasteful. Okay, so some medical organizations and I think kind of mainstream medical perspectives would prefer to focus more narrowly in allocation decisions on the matter at hand, right? So not on who is worse off over the course of their whole life or who's likely to have the best life after discharge, right? How many years of good life or quality adjusted life years an allocation decision or allocation policy is going to produce, but just more narrowly on the question of who's more likely to survive the given episode, right? So we should ventilate, if we can't ventilate all of the COVID patients in the emergency room, we should ventilate those most likely to survive, right? This seems to many to be the wise way to steward those resources. But I think the disability community and others have significant and serious concerns about this proposal. So one concern that a proponent of the health maximization approach might, I think, with some good reason, press, right? Even if we don't agree with their conclusion, we might think there's something to be said for some of their premises, is that this takes no account of the projected quality of life after survival, right? So we don't have to care about whether someone's life was good or bad before they came in to be to think that given two patients, one of whom is likely to become very seriously cognitively impaired after the results of the episode if they survive, and another patient who is likely to recover fully if they recover, right? That we might have some reason to treat the patient who's likely to recover fully. Now, of course, it's a very complicated issue, right? There's a very complicated set of issues around when and under what conditions we have reason to prevent someone from developing a disability when, if we listen to disability advocates, we might think that there's nothing so horrible in the end about a life with intellectual disability. But still, even those who think that it's not so horrible to live a life with intellectual disability think that, of course, medicine has reason to prevent people from developing this, right? And so given that principle, focusing solely on the chance of survival without taking into account at all the projected quality of life after survival, right, seems myopic and not sensitive to everything that ought to matter here morally. From a disability perspective, the survival to discharge principle, sort of now speaking in a way from the opposite direction, raises concerns about people who have chronic conditions, right? So not necessarily the people who are so badly off that they're they really can't be helped much by the ventilator, right? Remember, that was the concern about the priority for the worse off proposal. The survival to discharge proposal is troubled by people who have significant comorbidities, which make it less likely that they'll survive an episode, serious critical episode of COVID, even with ventilation, but who still, have some significant chance of surviving with ventilation and basically no chance without it, right? Under conditions where ventilators are really scarce or other acute care resources are really scarce, if we stratify people into likelihood of survival categories by way of, by reference to their pre-existing conditions, and there are going to be people, disabled people with multiple chronic conditions who are going to have basically no chance under that kind of scheme of receiving care. And there's something that does and it should bother us about the idea that there are certain people who are going to be certain categories of people identified by ascriptive categories like disability that are going to be simply left to die, right? Given no chance even in the dire circumstances where some people are in the end not going to get treatment. There's some intuitive pull to the idea that everyone should have a kind of shot at getting treatment. So one way that we might try to operationalize this proposal that everyone should have a shot at getting treatment has been proposed by at least some advocates for disabled people, including in the New York Times, an article early in the pandemic by Ari Naiman, is to go with a sort of simple first come, first serve principle. So this is, in a way, distributing resources randomly, right? So we're under this proposal, we're just ventilating people as they come in, and I suppose taking them off as they die, and no judgments are made about whether the next patient that we ventilate, no judgment is made about how likely they are to benefit or their quality of life or anything like that. It's just, are they the next person in line? So this can seem like this can seem fair, right? This can seem like a way of giving everybody an equal shot, and has seemed to some to be that. But it's actually not clear in the end that this is in the interests of people with disabilities or fair to them, right? So disabled and otherwise disadvantaged people often have difficulty getting prompt access to care, even just getting to the hospital, especially in pandemic conditions when mobility solutions may be limited and working imperfectly. And so we might think this is less clearly advantageous to disabled people than some proponents suppose. Another concern, and this is a concern for disabled people especially, I think, is that while there's a sense in which this distributes access to life-saving care randomly, because people don't choose when they get sick, there's another sense in which it really doesn't, right? In which it gives resources to people who get sick first, but people who get sick later don't have a shot, right? So we're back to this category of people we're back to the situation where there are some people who, might as well not even show up at the hospital not because they're not in the first instance because they're sick, but because it's now month 2 of the pandemic and all the ventilators are full and they know there's not enough of it's just a tiny chance that they're going to happen to be the person in line when one becomes available. And so the idea that we do a first come first serve approach is going to penalize people who come late, and among the people who come late are going to be people who are especially careful, right? Especially careful not to get sick, and they may be especially careful precisely because they know that they are especially endangered by their chronic conditions if they do get sick. And so I'm skeptical that a first come served approach actually does either is sort of intrinsically morally fair or really supports the interests of disabled people in general. Okay, so I spoiled the ending, which is that there is no ending, that I don't have a solution, but I do want to conclude with some lessons that I hope we can take from the kind of moral reflections that I've been suggesting here. Distinguish aspects of allocation policies that seem morally dubious from those that seem morally innocuous or even positively valuable. So it doesn't seem like a good idea. It seems wrong to discriminate in healthcare allocation on the basis of how healthy someone is anyway in their life or can expect to be, irrespective of what happens on this particular occasion, right? Irrespective of the course of say their COVID. Whereas I think it's more morally innocuous to distinguish those who will benefit more from treatment from those who will benefit less, right? So I don't think we could do without this idea in medicine when we have some kind of scarcity that we want to use our resources where they'll be most beneficial. But but this is a matter of taking into account how the treatment is going to, what kind of change the treatment is going to make to someone's quality of life, as opposed to taking into account how high their quality of life is irrespective of the treatment, right? Nor do I think it would be innocuous. I think it would be dubious, again, to focus only on the likelihood of surviving the episode. By contrast, I think that our moral worries about that suggest that whatever allocation method we use, it should give everyone a chance. Now, it may be consistent with that we give some priority to those who have better odds of surviving with that chance, right? Again, that might be part of using our resources wisely. But it seems to me to be morally unacceptable to leave some people with no chance of receiving the resources they would need to live, or at least not on the basis of their having a disability or chronic condition. That said, I don't think the way to give everyone a chance is to allocate acute care resources on a first come, first served basis. Instead, I think we would need to have some kind of judicious use of randomization or lotteries, some other way of randomizing other than by way of first come, first serve. And I wish I knew what that was. I don't. I think that's something that we could all think and talk about, how we might use, construct policies that use randomization or lottery procedures to distribute scarce resources in a way that isn't distinctively discriminatory against disabled people or other sort of groups that we would want to be careful not to disadvantage. So I know I'm running out of time. I just want to wrap up by pointing out that the use of a non-first come, first served procedure, right? Any kind of randomized non-first come, first served procedure is going to raise at least the prospect of needing to reallocate resources which have already been allocated, right? So needing basically to take someone off a ventilator when perhaps they no longer have a sufficient chance of survival to give it to someone else who has a higher chance, right? It seems like this is a concomitant of rejecting the first come, first served approach. I'm not, I'm aware that this raises difficult ethical questions about the ethics of withdrawing and withholding care, questions which have a long history in the Catholic tradition. I won't go into detail about those. I know those have been discussed in this series. I did just want to point out another point in the neighborhood, which is that some people who use ventilators, right? Some people whose ventilators might seem to be up for reallocation, people like Alice Wong, quoted here, should probably be left out of any reallocation scheme on the following grounds. Someone who uses a ventilator, not just for COVID, but throughout their entire life, someone who breathes by use of a ventilator, at least arguably, has a ventilator as a kind of part of their body, right? I breathe with lungs and diaphragm muscles. Alice Wong breathes with lungs and a BiPAP. And it seems that our society would be treating her as less than an equal if we made her breathing apparatus open to redistribution, whereas mine is presumably not. So that's not to solve all of the very difficult questions that would arise in any kind of reallocation scheme or departure from first come, first serve, but just to indicate some limits, I think, on the idea of taking away a ventilator that someone is already using. Okay, thank you for listening. I apologize for going a little long there. Happy to take your questions.
Thank you very much, Dr. Ross, for that presentation, especially for recognition of what the kind of guiding principles that have been used in the past and even used right now to help us to allocate and discuss triage, et cetera. You give a lot of kind of lessons, and I want to discuss a little bit around lessons learned, and it goes into a couple of the questions that have been asked so far. Many of the protocols that have been created were created a decade or so ago, right after H1N1 and a few after some other crises in the past. And so they weren't really well known by the public until this pandemic, and they kind of entered into the mainstream, right? People began to actually read these hundreds of page-long documents about triage and allocation, et cetera. And that's when many representatives of different populations, especially people with disabilities, kind of stood up and said, hey, wait a minute, there's a bias against us in some of these documents. There's some language here that isn't quite right, that isn't fair. There's some discrimination going on that wasn't originally probably intended, and it just wasn't observed by the people that were writing this a decade ago. So how can we learn from those kind of lessons when we update the policies moving forward, when we create new policies, and I'm sure we're going to have to create when this continues to rise? How would you help us in that regard?
Yeah, I think if you look at the different guidelines that were produced in different states and by different institutions, you'll see that some of them are better than others in these ways, right? Some of them have raised more objections than others. So, for instance, people may have heard about the guidelines in Alabama, which said something like people with intellectual disabilities are unlikely to receive these resources, right? Which is clearly a profoundly problematic exclusion if it's to be a categorical exclusion, at least. Whereas the New York State guidelines, though not immune to criticism, I think have received less pushback from the disability community. And I think that's, of course, it's because, their content is better. But the reason their content is better is that they were constructed by a task force, which involved significant representation from the disability community. In the case of the New York State guidelines, the late disabled philosopher of disability, Adrian Ash, served on that committee, and I know was very, very instrumental in producing the recommendations that they came up with. So, as is so often the case in policymaking processes that affect diverse communities, it's important to have representation.
Absolutely, yeah. Thank you for that. Some of the people on the presentation just want to know if we need to make a distinction, or if there's not so much of a distinction in this particular topic around disability and individuals with chronic medical conditions. What would you answer to that?
So, I mean, for certain purposes, right, depending on how we're applying different principles here, we might draw distinctions within disability. So I think I would refer to all of those as disabilities, like according to the Americans with Disabilities Act. People in all of those, both of those, all these categories are going to kind of disabled for the purposes of anti-discrimination law. But there is a distinction to be made, and I think people are picking up on, between people who think of their disabilities as just differences, right? People with kind of static, what the ADA would call impairments, like blindness or paraplegia, who are adapted to them and feel like my life is going just fine, right? People in that position, again, aren't going to have priority as amongst the worst off, and would at least argue that it's a deep insult to the way they live their lives to see saving their life as less valuable because they're disabled, right? So rather than distinguishing between disability and, say, illness, I think I would distinguish between those disabilities that make people's lives go worse and those disabilities which don't, or at least on some reasonable views don't.
Thank you. I think that's very helpful in understanding the kind of principles you're bringing forward and in the way that you've discussed it during this webinar. You mentioned way at the beginning that the principles can be used not only for vent allocation or resource allocation in a acute setting like a hospital, but perhaps also in medications and vaccine allocations. And I'm beginning to think of, I think many of us are beginning to think, how are we going to allocate vaccines, especially in light of what we will assume will be some sort of scarcity at the beginning. And one of the kind of leading arguments is that healthcare workers should get them first, that because they're on the front line, they should be able to get them first. And that kind of has not only a sense of we're trying to achieve the greatest, but we're a very utilitarian kind of understanding that might bias against individuals who have a disability because they're not able to physically provide certain treatment or not be able to physically contribute to the medical care of others. How would you respond to those comments?
Well, first, I would want to say on behalf of our colleagues with disabilities that are medical professionals, that of course
absolutely
do, but certainly when you're talking about the population of disabled people in general, it's a much higher rate of unemployment, and so the concern is well taken. There is a major distinction between the context of ventilators and the context of vaccines, that I'm sure many of our listeners are aware of, which is that, of course, when you save someone's life as a ventilator, save someone's life with a ventilator, mostly what you've accomplished is saving that one person's life. That's the bulk of the effect of that. Now, if that person is a doctor and they get to go back to work eventually and save other people's lives, that's great, right? But with vaccines, giving one person a vaccine protects other people, right? It protects everyone that they come into contact with, right? And so although I think concerns of fairness to disabled people have to be taken into account even in vaccine distribution, you have a kind of much stronger utilitarian case, I think, for vaccinating a healthcare worker, everything else being equal, than for ventilating a healthcare worker, everything else being equal. If you see what I mean, because you do more to protect other people, including ill and disabled patients of the healthcare worker by vaccinating them.
Well, that's all the time we have right now. So I wish to thank you, Dr. Oss, for being with us, to providing us your wisdom and guidance, and for giving this wonderful presentation. Thank you very much.
Okay, great. Thank you all for listening. I appreciate it. Thanks for.
And back to you, Ronnie.
Thank you. And on behalf of the Catholic Health Association and Georgetown University, I'd like to thank you for participating in today's event. The recording will be emailed and will also be posted on CHA's website at chausa.org, where you can also find recordings of previous sessions in this series. Today's program is copyright 2020 by the Catholic Health Association with all rights reserved. This concludes today's program. Thank you for joining us and have a wonderful day.